Well, it's a privilege for me, and also I think for the Foundation ECHO, to be the honor and to be glad to ask to have the presence of Dr. David Gandara. Is really one of the more relevant oncologists in the lung cancer field, and we have the opportunity to talk with him and to have to make some question about the burning issue in the lung cancer field actually. Dr. Gandara, nice to meet you.
Thank you.
And thank you for agree to be here with us and to answer our question. First of all, I would like to ask about the genomic medicine in the precision medicine in the lung cancer field. I think in the lung cancer field there are we have been an increasing number of oncogenic drivers, but my specific question is related to squamous cell lung cancer. Please answer what is your point of view about the potential potential target, actionable target in the squamous lung cancer.
Thank you. It's my pleasure first to be here at this meeting for biomarkers sponsored by ECHO. It's a wonderful meeting with fabulous speakers and a lot of nice discussion. And my presentation here today, and relevant to your question, is about the increasing need to do genomic testing in patients with lung cancer. Right now, in 2018, there are now 8 oncogenic drivers which are related to treatments which can be very effective with response rates over 50% for these different oncogenes. So in order to find those patients, you have to test. Almost all of these oncogenes are much more common in adenocarcinomas than they are in squamous cell lung cancer, and yet they are found in squamous cell lung cancer. So in particular, in squamous cell lung cancer patients who have never smoked, or perhaps are younger, or have a family history of lung cancer, we should be testing for those oncogenes. In other patients with squamous cell lung cancer, we know that there are oncogene drivers, but so far it has been very difficult to find the right targeted agents to treat them. So an example of this, or 3 examples I should say, PI3 kinase, FGFR abnormalities, and CDK4/6 abnormalities. We know in other tumor types that these are treatable, and that some drugs have even been approved to try to treat them in other cancers. But in squamous cell lung cancer, for example, we have completed 3 studies as part of the lung map, the lung master protocol in the United States. And for each of these abnormalities, although we could screen very nicely for them and accrue the patients, the response rates and the survival times were very low. Response rates generally below 10%. So what that tells us is we have to be smarter. We can't assume because a gene is important in breast cancer, for example, that the same gene can be treated in squamous cell lung cancer. I do think, though, that squamous cell lung cancer is a very good candidate for immunotherapy. It has high mutations and it has neoantigenic mutations. So maybe we should be devoting more of our time toward immunotherapy in squamous cell lung cancer.
Thank you. Moving to the immunotherapy field, that means probably change in the paradigm of treatment in lung cancer, and also open the windows for long-term survivor. in this very difficult disease, but we have a lot of potential biomarkers, a potential of predictive factors for decide the results of select the patients in this setting. Nowadays, do you think in the clinical practice, what are the potential biomarkers in this field that could be used currently or in the next future?
Well, thank you for that question. And again, I think we can't be too simple in our approach. My own belief, and this is important for patients, is that the checkpoint immunotherapies are targeted drugs. They target an abnormality in the cancer, but it's not so simple as testing for a mutation. And I say this because squamous cell lung cancer is very different from adenocarcinoma in terms of the kinds of mutations and the distribution of those mutations and how they affect what we call neoantigens that stimulate the immune system. So right now we have two biomarkers which have become more prevalent. One of them, standard of care, and that is to measure the PD-L1 level in a cancer by immunohistochemistry. And over the last 3 to 4 years, we've learned very much. For example, we've learned that although there are different assays for PD-L1, they're very different, they even use different instruments, that each one of them can identify patients who benefit the most. But moreover, some patients that have low expression of PD-L1 still benefit from these drugs and can be long-term survivors. In our analysis of long-term survivors from the drug atezolizumab, for example, 30% of the people who had lived over 2 years had no PD-L1 in their cancer. So there must be something more. And more recently, we have found, and others have done work, to show that measuring a tumor mutational burden in a cancer can help us predict who's going to benefit. And the most interesting thing, and surprising to me, I would be interested in your thoughts, is that PD-L1 and tumor mutation burden are very different. It doesn't identify the same patients. So maybe the next step is to do PD-L1 testing and tumor mutation burden. And then you're going to ask, well, what assay and how do we do it? You can't do a research test that takes 6 weeks to come back. But we now have commercially available tests, such as the Foundation Medicine test for TMB, with a turnaround time of 10 days and very comparable results to that of whole exome sequencing. In the United States, the FDA has given a breakthrough designation for the test for TMB, and we expect in the future that we will also be able to do this very accurately in blood. And we have a big paper coming out on that very soon. So I think right now we're in what I would call transition. We're moving from what's research to what would be standard of care in the clinic. But we're not there yet. Well, what are your thoughts?
Well, I think we can anticipate that in the next future, probably we need next generation sequencing for the metastatic lung cancer patient, and taking in mind the difficulty of the tissue availability, probably, as you mentioned, the next future, the immediate futures need to be moved to the blood test, to the testing the next generation sequences, testing the genomic, the white genome in the blood test. That probably is the tool that we can use in order to decide a better use of the different therapeutics.
I am in agreement. And if you ask patients, they would much rather give a tube of blood than have a biopsy. So at some point, we know we can do this already for genomics. for example. So if we could do this for immunotherapy to predict who would benefit, it would be very nice.
And another question, I know that you are especially active in this field, in this way, is about the treatment with immunotherapy beyond progression according the RECIST clinical criteria. That probably is related to the chance of long-term survival, but I am especially interested in your point of view in this question.
In this meeting today, we discussed this point. And I think the difference is, as oncologists, we have to think differently about immunotherapy, checkpoint immunotherapy, than we do about chemotherapy and targeted therapy. With those sorts of drugs, you expect the tumor to shrink, and you can measure this on a CT scan. But for immunotherapy, patients can have long-term survival even though there is no shrinkage in the cancer, and even if they progress so that the cancer looks like it's growing, they still live longer. So we have published on this in our manuscript on the OAK trial in Lancet, and we have hypothesized that immunotherapy affects the tumor biology in a way that allows longer-term survival because it stimulates the immune system, and that this can benefit patients even when the tumor appears to have grown on a CT scan. And we call this post-progression prolongation of survival, PPPS. We analyzed the OAK trial, and we found that patients who continued atezolizumab after progression by RECIST, as long as they were still benefiting clinically, they felt well, they didn't have a lot of toxicity, that the survival was very good, over 1 year, even after progression. So the FDA in the United States is very interested in this because the same thing has been observed in melanoma and in renal cell cancer. And our FDA has proposed doing prospective studies to see if with this category of drugs we should continue some patients after progression. We have a trial with the National Cancer Institute, a partnership between ECOG and SWOG called INSIGNA, which will start in about 2 to 3 months, where one of the arms is specifically investigating treatment beyond progression.
And do you think that is the same problem in first line or in second line, the treatment beyond progression?
I suspect it is the same. The analysis we did was in second line therapy, yes. But the trial I'm talking about is in first line therapy.
The new trial is in
yes,
first line.
Because we want to see if we can identify this in the first line of therapy.
Well, thank you very much, Dr. Gandara, for these interesting comments, and thank you very much for being here.
It's my pleasure.
It's my pleasure.